And if I can, oh, thank you. If I can get my slides to work here. There we go, okay. So yeah, thank you everyone for joining us this afternoon, and welcome to the second talk in our mini med school series. My name is Drew Smith. I'm a second year medical student at UBC, and the talk we're going to be covering today is the role of genetic testing in medicine. So what I'll be doing throughout this talk is covering some of the main areas of genetic testing in medicine. There are many different areas in medicine in which we conduct genetic testing, and unfortunately, I won't be able to cover all of them in this talk. This talk, as you maybe just heard recently, is being recorded, and the slides will be posted on Dr. Gare's website along with the recording. The link to the website can be found in the email you received that also contained the link to this Zoom call. So you can find the link there, and then maybe actually if one of my colleagues doesn't mind maybe popping the link to the website into the chat as well, that would be great. And as Dr. Gare mentioned earlier, we ask that you please keep your microphone turned off throughout the talk. If you do have any questions about anything, we ask that you wait until the break or the end of the talk to ask those questions, and then you can feel free to put your questions either into the chat box or you can turn your mic on and ask the questions, and I'll do my best to answer those questions. So I just want to start with a territorial land acknowledgement. I would like to begin by acknowledging that I am joining you from the traditional, ancestral, and unceded territory of the Lekwungen-speaking peoples, including the Songhees, Esquimalt, and WSÁNEĆ peoples, whose historical relationships with the land continue to this day. I also have a few disclosures before we continue. I am a medical student as well as my other colleagues who are doing these talks, so these talks do not constitute for substitute medical advice. This talk is on genetic testing, and genetic testing is a very complex topic. There are a lot of nuances and caveats and exceptions to things. And therefore, throughout this talk, I'm going to be glossing over a lot of details, maybe keeping certain things vague, and that's just trying to simplify things. So if any of you do have any prior knowledge or experience with genetics and genetic testing, you may notice me sort of going over things a lot more simply and not going into any details. And that's simply just to keep things simple and also keep ourselves within a reasonable time limit. Finally, if you do have any questions for yourself for genetic testing, please do consult with your healthcare provider. All right, so this is the outline for the talk today. We're going to cover screening testing, which includes prenatal screening and newborn screening. We'll cover cascade testing, carrier testing, and then we'll end with diagnostic testing. Before we get into the content, I have a few questions for you. This is on certain things that I'm going to be talking about throughout this talk. And I certainly don't expect you all to know all the answers to these things, but I'll get a poll going here for these questions. So let's see. All right, so you should be able to now submit your answers to this first question I have. Just give it a few more moments for people to participate. All right. So it looks like, share the results here. So yeah, so it looks like we had pretty good response there. Overall, 41% saying cystic fibrosis, and that indeed is the correct answer. So that is not something that is screened for during pregnancy. The other three are. So good job on that one. Oh,
can you remove the advertisement from the screen, please? Can you remove that?
Sorry, I'm just going through these polls here. And if you don't mind just keeping your microphone off during the talk, thank you. So we'll get on to the second question here. All right, so we've got the second. Give it a few more moments here for people to participate. All right, looks like most of you have, so I'll share the results here. So yeah, that's great. So most of you said phenylketonuria, and that is the correct answer there. All right. Just one more quiz question here. All right, looks like most of you have participated, so share that one. So a little bit more of a mixed result here. 36% of you though got it right there. It is Huntington disease. So again, these were kind of just to see what the knowledge base is going into the talk, and hopefully all of these things will be explained well enough to you for you to understand the answers by the end of the talk. All right, so I'll close off the polls there and we'll move on. All right, so our first topic is going to be on screening testing. This will include prenatal screening as well as newborn screening. And within these, I will also talk about the diagnostic testing that are done as follow-up to the prenatal screening and newborn screening, as it just makes more sense to talk about the diagnostic testing here rather than at the end when I talk about diagnostic testing more broadly. I do want to acknowledge that some of you may be wondering why I'm not including other types of screening testing, such as screening for various types of cancer, like breast cancer, ovarian cancer, or prostate cancer. And the reason is that for this talk, I'm wanting to more focus on purely genetic conditions, and those other things that we screen for, as I mentioned, breast cancer, ovarian cancer, and prostate cancer, are not purely genetic conditions, and therefore I'm not going to talk about them here. However, I will talk about BRCA1 and BRCA2 later on in the talk, which is a genetic mutation that does lead to higher instances of breast and ovarian cancer. And I'll talk about that a little bit more later. So before we get into the prenatal screening and the newborn screening, I just want to talk broadly about screening testing and what it is. So genetic screening is testing that is done in order to identify individuals in the population who are at an increased risk of a condition. So this means that if you screen positive for a genetic condition, it does not mean that you have that genetic condition. So it's not diagnostic. It simply means that you have a higher risk of that genetic condition. And similarly, if you screen negative for a genetic condition, it does not mean that you do not have that genetic condition. It just means your risk is quite low. So this diagram that I have here is just to try to show that in picture format. And this is actually is an example of the screening for Down syndrome, which is something I'll talk about soon. So as you can see here, all of these gray figures are those that were screened negative for Down syndrome and also do not have Down syndrome. So that would be called a true negative. And the majority of people will screen negative, as the majority of people do not have Down syndrome. However, there is a small minority, as you can see by these two green figures here, in which they will screen negative, but they will in fact actually have the condition. So that sort of helps to explain why a negative result doesn't mean you don't have doesn't mean that you don't have the genetic condition. It means that your risk is very low. So there's a very low chance that you could screen negative but actually have the condition. In the center of the picture here, we see people who screen positive. So the black figures here are those that screened positive, but in fact do not have the genetic condition. And the ones in the very center are the ones who screen positive and do in fact have the genetic condition. So again, this illustrates why a positive screen does not mean you have the genetic condition. In fact, a lot of people who do screen positive don't have the genetic condition. And that's why we need to do diagnostic testing after the screening test to try to confirm whether or not you do in fact have the genetic condition. So I hope that explanation sort of helps understand what screening testing is. All right, so moving on to our specific topics. So the first one is prenatal screening. So prenatal screening are a series of tests that are offered to pregnant women to determine if their fetus has an increased risk of certain genetic conditions. This includes trisomy 21 or Down syndrome, trisomy 18 or a neural tube defect. Now, one thing I do want to point out is I mentioned earlier that I was going to be focusing on purely genetic conditions when talking about screening. Neural tube defects actually are not purely genetic conditions. They can be caused by various things, both genetic and or environmental, but I haven't included here because this is one of the major things that we're looking for in prenatal screening, so I didn't want to leave it out. So trisomy 21 and trisomy 18 are genetic conditions in which we have a third copy of chromosome 21 in the case of Down syndrome and a third copy of chromosome 18 in the case of trisomy 18. And then a neural tube defect is an anomaly in which either the spinal cord or the brain does not form properly during development. So I have a diagram here. This is just showing some of the typical characteristics of a newborn with Down syndrome. Trisomy 18, I don't have a picture to show you for that. Trisomy 18 is something that typically will result in either a miscarriage or a stillbirth. And if a baby is born with trisomy 18, they typically do not live for very long, usually less than 1 year, but more typically only days or weeks they'll live for. Neural tube defects, as I mentioned, could either be improper formation of the spine or brain. If it's the spine, it's called spina bifida. So as you can see here in this picture on the left side here, the spinal cord is essentially not completely contained within the spinal column. It is covered by a small amount of tissue here, but it is at increased exposure and risk to being damaged. Spina bifida is something that can be surgically repaired, and I'll talk a little bit more about that later. However, even with being surgically repaired, a child with spina bifida is still going to likely develop, have neurodevelopmental problems, as well as motor problems, specifically for the lower limbs. So many children who do have spina bifida have very limited use of their lower limbs or are paralyzed. The other type of neural tube defect, as I mentioned, is where the brain doesn't form properly, and this is called anencephaly. Anencephaly typically is going to lead to a miscarriage or a stillbirth, and if a baby is born with anencephaly, they won't survive for very long. I also just threw in a small table here just to show you the risk of these different conditions. So chance of neural tube defect is about 1 in 1,000. Trisomy 21, trisomy 18 are less prevalent than the neural tube defects. However, they do depend on the age of the mother. So at greater age of the mother, they actually do become quite a bit more common than neural tube defects, especially for Down syndrome. All right. So what are we actually testing? What tests are we actually doing in prenatal screening? There's a few tests that are typically offered at first, and I'll just go through these. So one of them is called QUAD, and it's called QUAD because it's testing for 4 different molecules in the blood. And this is a blood test that will be done in the 2nd trimester. Another test that could be done is called serum integrated prenatal screening, or SIPS. And this is essentially where you're going to do that QUAD blood test in the 2nd trimester. And additionally, you'll do a blood test looking for a molecule called PAP-A in the 1st trimester. Another screening test that might be offered is called integrated prenatal screening, or IPS. And this is where you'll do the 2 blood tests involved in SIPS. And you'll also do an additional ultrasound called a nuchal translucency ultrasound. This is done between weeks 11 to 14. And I do have a picture here. So this is showing the nuchal translucency ultrasound. Essentially what we're looking for is a pocket of fluid at the back of the neck of the fetus. And essentially we're just seeing how large that fluid pocket is. On the left side, we're showing what a normal amount of fluid is. On the right side, you may be able to appreciate that it's a bit larger. And so that would be a positive test there for an increased level of fluid in the nuchal translucency ultrasound. If one of these tests comes back positive for Down syndrome or trisomy 18, or there are certain risk factors that warrant doing this test earlier on, we would move on to a test called non-invasive prenatal screening, or NIPT. This is a test that can be done anywhere from 10 weeks and onwards in the pregnancy. And essentially what we're doing in this test is we're collecting blood from the mother, and within that blood, there will be free fetal DNA. And so we can collect that fetal DNA within the mother's blood and then analyze it to look for these genetic conditions. I will mention with the prenatal screening, we're not only going to be able to find Down syndrome and trisomy 18, we can find other genetic conditions as well. So there's another trisomy called trisomy 13. And as well, there could be problems with the sex chromosomes or other genetic conditions that we could find. But we mainly are just talking about Down syndrome and trisomy 18 because those are the 2 most common ones that we're going to find. So those were all screening tests. So again, as they're screening tests, a positive result will just mean there's an increased chance for the fetus having that condition. Now we'll talk a bit about the diagnostic testing that is done. So if the QUAD, the SIPS, or the IPS came back as positive for a neural tube defect, the diagnostic test that is performed is a detailed ultrasound to confirm whether or not there is a neural tube defect. And again, this detailed ultrasound is not only going to pick up a neural tube defect if it is there, it could pick up other defects as well. But again, this is the main one we're screening for and trying to diagnose at this point. If that NIPT test is positive for Down syndrome or trisomy 18 or something else like trisomy 13, or there's certain risk factors that warrant moving on to the diagnostic testing earlier, we'll offer amniocentesis or chorionic villus sampling, and that'll be to analyze the fetal DNA further and to try to confirm the Down syndrome or trisomy 21, or sorry, I made a mistake here. This should say Down syndrome or trisomy 18 or trisomy 13. So amniocentesis essentially is where we remove a small amount of amniotic fluid, and then we'll analyze any cells and free-floating DNA within that fluid. Chorionic villus sampling is where we will take a piece of the placenta and then analyze the DNA from the cells that we collect from doing that. Amniocentesis is the test that's normally offered and conducted simply because typically by the time you're getting a positive result in an NIPT, it's past the point at which you could do a chorionic villus sampling. And so this is the test that we'll have to perform. And as I mentioned, these can find other genetic conditions. And with NIPT, although this is something that can be offered for free based on certain conditions or risk factors, or if you're getting positive results from these earlier tests, this is also a test that someone could pay for privately if they don't qualify for getting it for free, or if they wanted to do it earlier on in the pregnancy. And in that way, if you are doing this NIPT test earlier on and you're getting the results early enough that you could do chorionic villus sampling, you might do that, as you cannot do amniocentesis until week 15 and onwards. All right, so what next? So if we do get positive results from these diagnostic tests, whether it was a positive detailed ultrasound finding a neural tube defect, or we got a positive result from the amniocentesis or the chorionic villus sampling, what happens? So one of the things that is going to happen, and this will happen for the other types of genetic testing that I'll be talking about, but the mother will be connected with a medical geneticist or a genetic counselor to help explain the different options that are available and just help them decide what option to go with. So one of the options is to continue with the pregnancy and prepare for having a child with one of these conditions. As I mentioned before, neural tube defects can be surgically repaired. And I actually have a photo here, and apologies, it is a bit of a graphic photo, but this is actually quite an interesting and amazing photo here. This is a picture of a spina bifida surgery being done while the fetus is still in the uterus. And as you can see here, the fetus actually grabbed the surgeon's finger during the surgery, which is a pretty amazing thing that they captured there. And it is quite a complicated surgery. It can't be done at all centers, but it is possible to do the spina bifida surgery while the fetus is still in the uterus. However, typically the surgery is done shortly after birth. But if you do get the surgery done while the fetus is still in utero, it does reduce the risks and the complications associated with the spina bifida. The other option would be to end the pregnancy, and a third option would be to make an adoption plan for the baby. So that's covering prenatal screening. We'll move on now to newborn screening. So in newborn screening, what happens is that we will collect blood from the newborn within about 24 to 48 hours after birth from a heel prick. So that's what's being shown in this picture here, is the newborn's foot is here, the heel has been pricked, and they're just spotting this blood spot card with the newborn's blood. And then that blood will be analyzed to screen for 24 rare but treatable disorders. And there's 4 main categories of these disorders. There's metabolic disorders, endocrine disorders, blood disorders, and then cystic fibrosis. So we'll go through those 4 categories and talk about some examples. So the metabolic disorders, these are essentially different genetic disorders that make it make the body unable to process certain molecules. And this is going to lead to toxic accumulation of certain molecules. And possibly as well, we could have deficiency of certain molecules. If metabolic disorders are left untreated, they can lead to various symptoms. There's about 15 different metabolic disorders. So as you can imagine, there's quite a range of different symptoms that can result from these metabolic disorders not being treated. But many of them lead to serious problems such as neurodevelopmental disorders, and some of them can even lead to coma or death of the newborn or child at some point, if left untreated. The example that was mentioned in the quiz questions earlier on is phenylketonuria, or PKU. And this is a condition where the amino acid phenylalanine cannot be processed. And I have a small diagram here just showing what phenylalanine normally is converted into tyrosine. So phenylalanine and tyrosine are both amino acids, which are building blocks of proteins. So essentially this process of converting phenylalanine into tyrosine is no longer happening, and we get a toxic buildup of phenylalanine, which does get converted into other molecules that are toxic. So how do we test for the metabolic disorders? Well, when we're analyzing the blood that we got from the heel prick, we're essentially going to be analyzing either certain levels or characteristics of various molecules that are associated with each of the different disorders. So for example, when we're screening for PKU, we're going to be analyzing the phenylalanine levels in the blood. So that's will be for screening, and then any positive results that we get from the screening will lead to further analysis of specific molecules in the blood or the urine or both to confirm the disorder. So this would be the diagnostic testing part of it. So for PKU, we would then retest the phenylalanine levels as well as the tyrosine levels to confirm PKU. So we'd be expecting in PKU to see phenylalanine levels being high and tyrosine levels being low. As well, we can also do a genetic analysis for some of these conditions to help confirm the disorder. In the case of PKU, there is this gene called PAH, and that is the gene that is involved with PKU and doesn't allow for the proper processing of phenylalanine. So if we wanted to further confirm the diagnosis of PKU, we could analyze the newborn for that gene and assess what the mutation was. In terms of treatment for the metabolic disorders, they're mostly dietary changes. So that's what makes this screening very key, is that it's actually not too difficult in many cases to help treat and prevent a lot of the complications that can happen with these metabolic disorders, because most of them are just dietary changes. For example, in phenylalanine, it's simply just having a low phenylalanine diet. And this is just an example here of a nutrition facts label. And if something contains phenylalanine, it'll have this warning here. So people with PKU, or obviously early on in the child's life, the parents of the child with PKU will need to just look for things that contain phenylalanine and try to avoid those things. They do need some phenylalanine in their diet. Obviously, phenylalanine is still something that's required, but you don't want too much of it so that it doesn't build up to toxic levels. Some of the metabolic disorders will require supplementation. As I mentioned, sometimes with these disorders, it's not only leading to toxic buildup, but we're also deficient in certain things that we need. So that might require supplementation, or they might early on in life need a special type of formula to get those supplements or whatever nutrients they need that they're lacking. Some cases they will require medications, but as I said, early treatment can lead to reduced complications, or in some cases, children can have a completely normal life if these things are caught early on and treated right away. All right, so we'll move on to the endocrine disorders. There are essentially two endocrine disorders that are screened for in the newborn screening. And these are basically things that will result in low levels of certain hormones. So I know these are kind of big names here. I'll break it down briefly. So congenital adrenal hyperplasia. So congenital just means it's something you have from birth. And then adrenal hyperplasia is just meaning enlargement of the adrenal glands. So the adrenal glands sit right on top of the kidneys. And essentially in a congenital adrenal hyperplasia, we're not producing enough of the hormones cortisol and aldosterone. And this leads to something we call a salt losing crisis. Essentially what happens is that you have far too little sodium in your blood and too much potassium in your blood. And this will lead to various different symptoms, vomiting, you can start to have seizures or other cardiac abnormalities, especially with the potassium levels being quite high. And of course, if this goes untreated, this could lead to death of the newborn or child. Congenital hypothyroidism, again, congenital just meaning that you have it from birth. Hypothyroidism basically is meaning that we have low levels of our thyroid hormone. So not having enough thyroid hormone in adults isn't a super serious issue. It does cause a lot of various symptoms, but in a newborn, having not enough thyroid hormone is actually very critical, as not enough thyroid hormone in a newborn can lead to intellectual disability and what we call failure to thrive, which is essentially where the newborn isn't growing and developing properly as we would expect. And this is usually due to feeding problems. And so they're not getting enough nutrition, so they're not growing properly. And then the intellectual disability, as well as the low nutrition, can lead to delays in development. And again, the thyroid gland, just showing it here, is just in your neck, kind of below your Adam's apple. So how do we test for these disorders? Well, for the congenital adrenal hyperplasia, we're measuring a certain molecule, 17-OHP, also 17-hydroxyprogesterone. I know this is a bit of a complicated diagram here, but I'll just try to briefly cover what the main things I want you to know about here. So essentially what we have is within this whole big process, we're trying to produce aldosterone and cortisol, and essentially we can't get past these 2 points here. So we get a buildup of this molecule, 17-hydroxyprogesterone. So we can measure the level of that molecule as our screen. So in this condition, we would expect this to be high. If we get a positive screen by seeing this as being high, then we can move on to diagnostic testing to confirm this. And this is done by measuring the levels of other adrenal hormones, such as aldosterone and cortisol. And we can also analyze a specific gene. I know this just looks like a long string of letters and numbers. So the CYP21A2 gene is what's involved in this condition. So we can analyze that to confirm the diagnosis. With congenital hypothyroidism, we actually, although we are low in thyroid hormone, so thyroid hormones are listed here, T3 and T4. In the screen, we're actually going to measure the levels of TSH. And so the reason for this is that if these hormones are low, then our TSH will be high, because essentially our body is trying to stimulate our thyroid to make more of T3 and T4. So it detects low levels of these molecules, so it increases this molecule to try to tell the thyroid gland to make more of this. So our screen is to measure the TSH levels, and we would expect it to be high. And then if we do get a positive screen there, we'll move on to a diagnostic test where we'll repeat the TSH level, and we'll also look at the levels of T3 and T4. And of course, we would expect those to be low, and that'll help us confirm congenital hypothyroidism. What's the treatment for these endocrine disorders? Well, it's essentially to replace our deficient hormones. So in the example of congenital adrenal hyperplasia, we're going to be trying to replace aldosterone and cortisol. In the case of congenital hypothyroidism, we're going to be giving thyroxine. So we're giving them synthetic thyroid hormones. And again, like with metabolic disorders, early treatment does improve the prognosis. And in this case, prognosis is quite good. And children with these disorders can lead fairly normal lives if they are treated early on, albeit with regular monitoring of those hormone levels, just to make sure that they are in the proper ranges. All right, so moving on to the next one, we have blood disorders. So blood disorders are essentially where we have problems with hemoglobin, and hemoglobin is the part of the red blood cells that carries oxygen. So it's a large protein that carries oxygen in our red blood cells. And in these blood disorders, the hemoglobin is either changed in some way or there's a reduced amount of the hemoglobin. So the blood disorders, the main one is sickle cell disease. However, there are other hemoglobin disorders that we're also checking for. These can lead to various symptoms, one of the main ones being anemia, but they can also lead to things such as pain crises, tissue ischemia and organ dysfunction, increased susceptibility to infection, and others. So I've got a diagram here just showing what's going on in sickle cell disease. So in normal red blood cells, the hemoglobin forms properly and distributes properly within the red blood cell. And we have red blood cells that have these characteristic biconcave disc shape. So almost like a donut, except for the middle's not a hole, it's just very thin in the center. In sickle cell disease, essentially the hemoglobin isn't formed properly, and so it starts clumping together, and we get these sickle-shaped red blood cells. And these sickle-shaped red blood cells have a problem moving through smaller blood vessels properly. They more easily lead to clots, and they also are more prone to breaking down. And so this is part of why we can get anemia with sickle cell disease, is destruction of these red blood cells, and the body is not able to keep up with the destruction of the red blood cells. The pain crises I mentioned here is related to the susceptibility of the blood clots. So essentially what can happen in people with sickle cell disease is they can have multiple blood clots throughout their body. And as you can imagine, that's extremely painful when you're blocking off blood vessels to different tissues and there's starting to be tissue ischemia. And then this is why it can lead to organ damage in certain cases. And then the increased susceptibility to infections is also a problem, which of course in a newborn is additionally a problem because infections in a newborn can really delay their development and create a lot of issues for them. For the blood disorder testing, I'm not going to go into it very much. There's various methods that are used to screen for and then confirm these disorders such as sickle cell disease. But essentially what all of the different methods that are used are doing is just trying to analyze the hemoglobin and ascertain what's wrong with the hemoglobin, or if there's something wrong with the hemoglobin. Furthermore, analysis of the genes that produce hemoglobin can also be done to help confirm the diagnosis. And one additional thing is that testing can also find carriers of hemoglobin disorders. I'll talk about carrier testing later on, but these carriers are people who are healthy, but they do have a genetic mutation that they're carrying. And like I said, I'll talk about that a bit more later on in the talk. In terms of the treatment for these blood disorders, there's various things we can do. We can provide symptom management through certain medications, and in some cases we can provide a blood transfusion. Of course, this is basically by giving blood that has normal hemoglobin, and so therefore we can manage some of the symptoms such as the anemia. However, this is not a permanent this is not a permanent solution, as our red blood cells do degrade, of course, and we need to produce new ones. So eventually the nice red blood cells with the proper hemoglobin we get from the blood transfusions will eventually be degraded and replaced with the improper red blood cells that the person's producing. So blood transfusions do help, but they're not a permanent solution. There's also prophylactic antibiotics that can be provided, as well as immunizations, and this is to help reduce the chances of infections and the complications that come with infections in early life. Again, same thing with the same thing as the metabolic disorders and the endocrine disorders. Early management of these blood disorders does improve the prognosis by avoiding the complications associated with the organ dysfunction and the infections. But the only way to treat this disorder these disorders has normally been to get a bone marrow transplant. And that, of course, is a complicated procedure. Not everyone's able to get a bone marrow transplant. However, there are new treatments that are emerging, such as gene therapy. So gene therapy is where we can actually basically go in and repair or change or replace the genes that have been mutated so that we can have the person producing their own hemoglobin that works properly. And so this is a very new emerging area of medicine, and I'll talk about this again when I'm talking about cystic fibrosis, and I'll provide some resources about gene therapy at the end of the talk, but I won't really be going into gene therapy too much in this talk today, as it's a very complicated topic and we don't have enough time to go over it. All right, so cystic fibrosis, so this is the last category as part of the newborn screening. Cystic fibrosis, I'm sure many of you have heard of it. It's a life-limiting disease, and it's caused by one specific gene called the CFTR gene. So there's a mutation within that gene that is causing cystic fibrosis. And this causes various things, the main one being mucus buildup in the lungs and other organs. So as shown in this diagram on the right here, we have at the top normal airways and then airways of someone with cystic fibrosis, and we see that they're plugged up with a lot of mucus. And this mucus is actually a nice area where bacteria can hang out in, and so that's why people with cystic fibrosis do have a problem with recurrent lung infections, because the bacteria just isn't able to be cleared out of their lungs, as it's able to stay within the mucus and continually cause infections. Of course, having this mucus is going to lead to breathing difficulties as well. And as you might notice on this diagram here, it mentions the pancreas and intestines are also affected. And so this can lead to problems with digesting food as well. Testing for cystic fibrosis involves multiple steps. So again, from that heel prick that we're doing at the beginning, we can test the blood for a molecule called immunoreactive trypsinogen. And then we can also do DNA testing of the CFTR gene from that blood test. The results of these two tests might require a further blood spot card to be made up at about 21 days or 3 weeks of life to retest the IRT levels. But then testing positive results from these screening tests will lead to diagnostic testing. And the diagnostic test for cystic fibrosis is called a sweat test. And so this diagram here on the right is showing what's happening with the sweat test. Essentially what we have is 2 electrodes get placed on the arm. One of the electrodes will have a special chemical put underneath it, and then a current will be put through here, and that'll basically draw the chemical into the skin, into this area of the arm, and that'll essentially cause that area of the arm to sweat a lot. And then once you've done this for a while, then you'll basically place a type of filter paper over top of the area that has a lot of sweat on it, leave that on for a while, collect enough of the sweat, and then essentially you're trying to measure the salt levels inside the sweat. As someone with cystic fibrosis will have very high levels of salt in their sweat. And so that's the diagnostic test. terms of treatment, there's quite a lot of different things that we can do to try to manage cystic fibrosis. Early on, we can start doing breathing exercises and physical therapy for the newborn child, and this will try to help clear that mucus from the lungs, which will help with breathing and, of course, trying to prevent recurrent lung infections. As well, we can provide them with antibiotics to prevent or treat the recurrent lung infections. And as I mentioned, the pancreas does get affected, and the enzymes that the pancreas normally releases to help with digestion of food aren't able to get released because of the mucus buildup. And so people with cystic fibrosis typically will take pancreatic enzyme supplementations to help with digestion of foods, which can, of course, help with making sure they're getting the proper nutrition and growing and developing properly. As I mentioned earlier, gene therapy is something that's a newer type of medication that's being researched right now. And again, I'm not going to go into that, but I'll provide some resources at the end. And there's many other medications that can be used to try to manage cystic fibrosis. Once again, like I mentioned, with the other conditions we're screening for in the newborn screening, early management can greatly benefit infants. Unfortunately, with cystic fibrosis, depending on the severity of the disease, eventually the person with cystic fibrosis may require a lung transplant. And unfortunately, if this isn't able to happen, a lot of people will have shortened lives because of cystic fibrosis if they're not able to get that lung transplant. But hopefully the new gene therapy that is coming out will be able to change that. All right, so we have reached our break. So we'll take a 10-minute break at this point. So it's 1:51, so we'll start up again at about 2:01. Again, if you do have any questions or anything at this point, feel free to put those into the chat, or you can turn on your mic and I'll do my best to answer those questions. I have a question from someone. Okay, I will try to respond to that at the end by messaging you. Okay. Were there any other questions before we get going? All right, we'll continue on then. Okay, so the next things we'll talk about are cascade testing and carrier testing. So what is cascade testing? So cascade testing, as it shows in this diagram here, is essentially where someone in a family is found to have some type of genetic condition. And once that is found, we choose to start looking and testing the family members of that person to see if they also have the same genetic condition. This gives a pretty nice description here. So it's the process of testing through a family in a specific order to identify all of the relatives who did or did not inherit a genetic mutation that is causing the condition of concern in the family. Again, I'm in this talk glossing over certain details, but typically cascade testing is associated with dominant genetic conditions. And a dominant genetic conditions is where only one mutated copy of a gene is required to cause or increase the likelihood of a specific disease. So this picture here just gives a bit of an illustration of what the inheritance of a dominant genetic condition could look like. So in this example, they're saying that the father has the genetic condition, so one of their copies of the gene is mutated, whereas the mother doesn't have any mutated copies, so she doesn't have the genetic condition. And in this scenario, just based on the odds of how the genes could be passed on to children, about 50% of their children are about 50% chance of having a child with the genetic condition and a 50% chance of having a child without the genetic condition. So there are many different dominant genetic conditions. I'll just talk about a couple of examples. So one of them is BRCA1 and BRCA2. So these are two different genes, BRCA1 being one gene, BRCA2 being a different gene. And if one of these is mutated, this will greatly increase the likelihood of breast cancer and ovarian cancer specifically, but as well as other cancers. And the other example that I will talk about is Huntington disease. This is a neurodegenerative disorder. It's shown here in this diagram. On the left side, we have a brain from someone who had Huntington disease. On the right side, we have a brain of someone who doesn't have Huntington disease. And as you can see, there's a lot more spaces here. There's a lot less brain tissue in the patient who had Huntington disease. So it's a neurodegenerative disorder, and this will cause many issues with movement as well as cognition. So thinking, memory, that sort of thing. And you might be wondering with BRCA1 and BRCA2, what if you have a mutation in both of these genes? So having a mutation in one of them greatly increases your likelihood of breast or ovarian cancer, as well as other cancers. If you have a mutation in both, typically what this does is it means that the onset of the cancer will be much earlier than it typically would be. So how can cascade testing help? Obviously, again, there's many different types of conditions that could result in cascade testing. So it depends really on what the condition is, but it can help an individual prepare in many different ways. So for example, if you do have a family member that is diagnosed with a genetic condition, cascade testing is done, and you elect to have your genetic test done, and it's found that you also have the same genetic condition that they have, that can help you prepare for that genetic condition in various ways. For example, with BRCA1 and BRCA2, someone who say a woman had her mother was diagnosed with having a BRCA1 or 2 mutation, and then through cascade testing, they were found to have that same mutation. They could start to have increased screening. So they could go for screening more regularly, or they could start their screening for things like breast cancer and ovarian cancer earlier on in life to hopefully find those cancers earlier. They can also perform risk-reducing surgery. So someone could have mastectomy, so removal of the breast tissue, or a surgery called salpingo-oophorectomy, where essentially the ovaries and the fallopian tubes are removed. And so again, these are trying to essentially avoid any sort of breast or ovarian cancer from developing at all in the first place. With Huntington disease, unfortunately, there's no cure for Huntington disease, and there's no good way that we have to slow the progression of the disease. However, we do have medications that can be used to reduce the symptoms, especially the motor symptoms and some of the cognitive symptoms. So that might make you wonder, why would someone really want to find out about Huntington's disease when they don't have it yet, and there's nothing that can be done, even if it is found that they have it. And this is a real dilemma for people when Huntington disease is found in their families. So some people, when a family member is diagnosed with Huntington disease and cascade testing is offered to the family members, some people will choose not to do the testing for Huntington disease simply because there's not a whole lot that can be done, even if it is found that they have it. And so some people just don't see the point in doing that. But some people might choose to do that, again, to help them prepare in many different ways. So that's up to the individual to choose whether or not they want to have that testing done or not. All right, carrier testing. So carrier testing is essentially where we do genetic testing of an individual based on the presence of a genetic condition within their family, or it could be due to them belonging to a certain group. And by certain group, that could mean various things. It could mean Usually it means a certain nationality or a certain ethnic group, where certain conditions might be more prevalent within that nationality or ethnic group. Or it could be where they live specifically within the world where certain genetic conditions are more prevalent. And again, this is glossing over details, but typically carrier testing is associated with recessive genetic conditions. So whereas dominant genetic conditions were conditions in which you only need one copy of the mutated gene, and a recessive condition, you need two copies of the mutation. So both the version of the gene that you get from your mother and the version of the gene that you get from your father, both of them have to be mutated in order to have the genetic condition. So again, this diagram is just breaking down what the odds are of having a child with the condition, and it's about a 25% chance versus a 50% chance with dominant conditions. And this is in the case that both the mother and the father are carriers of the condition. And what carrier means is where one of the genes is mutated, but the other one is normal. And in that case, typically the carrier is healthy. They don't have the genetic condition, but they do carry one copy of the mutated gene. So they have a chance potentially for passing on that mutated gene in the future. And that will bring us into why the carrier testing is done. But before that, I'll just talk about some specific examples of recessive conditions. So I mentioned earlier about sickle cell disease. And if you may remember, I mentioned that when we're doing the diagnostic testing for sickle cell disease, not only can that diagnostic testing as part of the newborn screening find people that have sickle cell disease, but it can also find the carriers of sickle cell disease. And again, these people are healthy. They don't have sickle cell disease, but they carry the genetic mutation. So this is just another diagram similar to the one on the previous slide, just showing the breakdown. If we have a mother and a father that are carriers of the sickle cell mutation, they have about a 25% chance of having a child with sickle cell disease. And then they also have a 50% chance of having a child with that is a carrier. And this is with sickle cell disease called sickle cell trait. This map is showing the prevalence of sickle cell anemia from sickle cell disease in the world. As you can see, there's quite a lot of sickle cell anemia within Africa and Southeast Asia. There's also higher prevalence in the United States and parts of South America as well. This is actually quite an interesting disease in that where it's more prevalent is actually associated with malaria. And this is something that you may be aware of. So these areas where sickle cell disease is more prevalent is also the areas where malaria is more prevalent. And the reason why these two things are related is a little bit complicated, but I'll try to explain it. So essentially, if you don't have sickle cell disease and you're not a carrier for sickle cell disease, you're at risk to malaria if you're living in one of these areas. And of course, because medical treatment isn't as widely available, a lot of people will get malaria and then will die from the malaria. People with sickle cell disease, again, because unfortunately medical treatment isn't as widely available in these areas for a lot of people, people with sickle cell disease are at much greater risk of dying from their sickle cell disease. Interestingly, people who are carriers of the sickle cell mutation actually have a lower risk of contracting and suffering from malaria. And I won't go into why exactly that is, but because of that, people with sickle cell trait don't have sickle cell disease, so they're not dying from that. And they also are at a lower risk of having malaria, and so they're not dying from malaria. So people who are carriers of the sickle cell trait tend to be more prevalent in these regions. And if you have a large part of the population being carriers, then of course you're tending to have more people being born with sickle cell disease. So I hope that sort of makes sense as to why sickle cell disease is more common in these areas. In terms of the United States, As you can imagine, there's more of a prevalence of sickle cell disease related to the larger African American population in the United States, where again, Africa is one of the main areas where sickle cell disease is more prevalent. Another example that I'll briefly talk about is TaySachs disease. So TaySachs disease is where there's a problem with breaking down fatty acids. So there's a specific enzyme that is not working properly. So this diagram at the bottom here is just showing that there's a mutation with this gene called the hexa gene that makes this enzyme called the hexa enzyme. And you end up with buildup of fatty deposits within the nerves of the brain. And with these fatty buildups in the brain, you end up with seizures, intellectual disability, vision loss potentially, and early death of the child. Typically, children don't live past the age of 4 with Tay-Sachs disease. They can live longer than that, but typically they do have a greatly shortened life, unfortunately. And Tay-Sachs disease is actually more common in people of Ashkenazi Jewish descent, French Canadian descent, and Cajun descent. So with both of these things that I've talked about, with the sickle cell disease and with Tay-Sachs disease, typically, if you are part of these groups of people, so again, I'll just go back here. So if you are of, say, African descent, or you're of descent from, say, India or other countries where sickle cell disease is more prevalent, then it's more likely that you'll be able to get these carrier testing done to check for sickle cell disease. Similarly, if you're of Ashkenazi Jewish descent, French Canadian, or Cajun descent, you may be eligible to receive genetic testing or carrier testing for Tay-Sachs disease. And why would we do this? Well, the main reason is for family planning. So as I mentioned before, someone who is a carrier doesn't have the disease, but they carry it and they could pass it on. So if you know you're part of, say, you're Ashkenazi Jewish, and you know that you have this higher risk of carrying the mutation for Tay-Sachs disease, and you're wanting to have a child with your partner, and you're wanting to know, is there a risk that I could be passing this on to a child and potentially have a child with Tay-Sachs disease, then you may conduct carrier testing for yourself and then maybe for your partner as well. If they're also of Ashkenazi Jewish descent, perhaps both of you will conduct carrier testing to see if either one of you are carriers. And if you're both carriers, then you would probably want to be speaking with a genetic counselor or a medical geneticist to discuss your options and to go through things with them. If only one of you is a carrier, this of course means that you won't be able to have a child with the genetic condition. So say only in this case, if the father was the only one that was the carrier, but the mother had 2 normal copies, there's no way of having a child with the genetic disease, but you can have a child that is a carrier as well. And then it would be good to know for that child in their future, for family planning, they might know that they could be a carrier, so they might want to do carrier testing in the future as well. So that's the main reason why we do carrier testing is centered around family planning. All right, so I just wanted to pop in another question here just to make sure everyone's got this whole dominant recessive thing understood. So I'll get the quiz question here. So you can just participate here and submit your answer for this question. So which type of genetic condition requires receiving a mutated version of a gene from each parent to get it, or from both parents to get it? I'll just give another moment here for people to participate. All right, it looks like most of you have, so we'll share that. All right, so it looks like most of you have got it there, so it's recessive. So again, you need both copies of the gene, the one from your mother and the one from your father has to be mutated in a recessive genetic condition, and dominant, only one of them has to be mutated. All right, so continuing on here. So our last topic here is diagnostic testing. This is probably what most of you would think of when you think of genetic testing. We're thinking about testing someone because we think they have some sort of disease that has a genetic component to it. So we want to do genetic testing to see if they have a specific mutation associated with the disease. So diagnostic testing, we mentioned it earlier on with the prenatal screening and the newborn screening used to confirm those different conditions, but there's various other areas where we can use diagnostic testing. This is not an exhaustive list that I've put in here, but I've just put in some specific things as well as just some general things. So these are situations where we might expect there to be a genetic component to the disease, and so we'd want to maybe do genetic testing, or at least offer the genetic testing to the patient. So this would include intellectual disability, multiple malformations of a child. So if a newborn is born with several different malformations of their face, or maybe they have a heart condition as well that's found, this would make us think that there's maybe a genetic condition versus them being born with, say, just one facial abnormality is not making us think as much of a genetic condition going on as compared to several malformations. Recurrent miscarriages and infertility in some cases can be due to certain genetic conditions. If there is a disease that we think someone has that we know is due to a genetic condition, or in some cases is due to a genetic condition, this could be a reason why we would want to do genetic testing. If someone has a disease and there's a strong family history of that disease, then we're more likely to think that there's a genetic component to the disease and we'd want to do genetic testing. And if the disease is more severe or has an earlier onset than expected, that would make us believe that there could be a genetic condition. So again, if say someone had breast cancer at a much earlier age than we would expect, we might start thinking that maybe there's a component of the BRCA1 or BRCA2 mutations, or both of them going on. So diagnostic testing has a lot of challenges associated with it. I know throughout this talk, I've tried to make things quite simple and straightforward, or as straightforward as I can make it. But there's a lot of gray area. So the results of diagnostic testing is not black and white. One component of this that can be problematic is what we call a variant of uncertain significance. So when we do genetic testing, and I haven't gone through all of the specific types or forms of genetic testing that is done, but in certain types of genetic testing, we can get what we call a variant of uncertain significance. And this is a bit problematic because what a variant of uncertain significance is that we found some sort of genetic mutation, but we don't really know what it means. It doesn't mean that if we find a VUS, it doesn't mean that it's probably benign, but it also doesn't mean that it's disease causing. It simply means that there's not enough information in the literature for us to be able to determine whether or not it's associated with the disease that we're seeing in a patient. So that's one aspect of the problems that we have with genetic testing, is sometimes we find things through the genetic testing that we don't really understand whether or not it is related or is not related to the disease that we're trying to assess. And so this is where the art of medicine comes in. The clinical context becomes very important when we are finding a VUS in certain cases. If we're seeing a strong family history, or we have other indications that makes it very likely that they have a specific genetic condition causing a disease, even if we find a VUS, we're more likely to think that the VUS is related. However, if we're seeing something that, is just some random VUS that we found on genetic testing, and we're testing it for some disease that's very vague, and we don't always know if there's a genetic condition associated with it, then we can be stuck really unsure of what to do with that VUS. So again, that's just part of the challenges we have with genetic testing. There are other problems with diagnostic testing as well. So there's something that I didn't really talk about, again, to try to keep things more simple for this talk, which is expressivity and penetrance with genetic conditions. So I've got the example of Huntington disease here for penetrance. So what penetrance means is essentially that in some genetic conditions, even if you have that genetic mutation, sometimes it means that you won't actually develop the disease associated with that mutation. So for people with Huntington disease, some people who do have the genetic mutation that we would typically associate with developing Huntington disease later on in life, some people don't actually end up developing the disease at all. So that becomes problematic. And if someone is, say we do cascade testing, they have a relative that was diagnosed with Huntington disease, then they got the genetic testing and they were found that they have the same mutation, they might believe, okay, I'm going to develop Huntington disease later on in life, but unfortunately, it's not as clear as that. And in some cases, people may not end up developing the Huntington disease, which is great for that person, but of course can cause a lot of stress for that person throughout their life. So this is another reason why some people for Huntington disease don't end up doing the cascade testing, simply because they don't want to know, because it might actually end up not meaning anything, even if they do get that positive result on the genetic test. So again, that's problematic. Variable expressivity. I won't go into this too much, but basically what it means is that you could have multiple people with the same genetic mutation, but they could have different presentations of the disease. So you could have one person that has a very severe expression of the disease, one person has a very moderate expression, one person has a very minor expression of the disease. So in some cases, when we do these genetic testing, we don't actually know how severe it might be. So if they had, again, cascade testing for some sort of dominant condition, even if they do get a positive result on that test, we don't actually know how bad that disease is going to be once they do start having the symptoms of the disease. So again, this is just creating more problems with understanding and helping people manage these diseases or plan for these diseases. Another issue is multifactorial. So some diseases are multifactorial, which basically means that there's both a component of genetics and the environment associated with development of the disease. So I mentioned neural tube defects earlier on in the talk. Neural tube defects can be associated with certain genetic conditions. We were talking about Down syndrome and trisomy 18. Those can lead to increased risks of having a neural tube defect. But there's other things that can also lead to neural tube defects. You may have heard of folic acid supplementation for women in pregnancy. So folic acid is something that's essential for proper formation of the spinal cord in the brain and development. And so we recommend women before and during their pregnancy to supplement with folic acid. So this is actually something that's not related to genetics. It's something that's environmental. And in neural tube defects, it could be an interplay of both things. So this is where things can get very complicated in terms of what could be causing a disease. So even though we're finding a genetic mutation, it could require some environmental things to actually get to the point of a disease. Another problem with genetic testing, for diagnostic tests, the wait time for the results can be quite long in some cases, or the wait time to be able to see a medical geneticist can take quite a long time. So for example, I believe in BC for the hereditary cancer program, for the BRCA1 and CA2 mutations, it can take several months or upwards of a year before you can see a genetic counselor or a medical geneticist to get the testing and be able to go through the decisions that are available if you do screen or test positive for BRCA1 or BRCA2. There's also of course, lots of limitations with access. One thing is that not everybody can do all of these testing. Sometimes in cases where it's part of a provincial or federal program, where the testing is free, but you have to meet certain criteria, there's people that might not meet the criteria, and therefore they're not able to get the testing done, even if they are worried about potentially having a certain genetic condition or carrying a certain genetic condition. There's of course also limitations to access when it comes to paying for certain genetic testing that aren't covered. So for example, when I was talking about in prenatal screening, I mentioned NIPT, and that this was something that you could actually pay for it. Of course, if people aren't able to pay for it, but they don't meet the requirements to do NIPT or have it covered by the government, then they may not get the NIPT done. So there are many limitations to access for these genetic tests. And all of these things lead to a lot of different problems with getting testing done, being able to find the diseases, understanding the diseases, and then being able to properly treat people who do test positive for certain genetic conditions. So you may be wondering why would we try to do all this testing then if it's so confusing? Well, of course, there are many reasons why we'd want to do this testing. As I'm explaining here, family planning again is a major part. If a family can do, say, carrier testing and find out that they do carry a genetic disease, or maybe they have a genetic disease that they know they could pass on. For example, Huntington disease, they might do cascade testing. They find out that they have Huntington disease, and then that might change their family planning on whether or not they want to have kids or the different ways that they could have kids. Diagnostic testing can help with initiating or adjusting treatment or management. So as I was talking about with the newborn screening and diagnosis, many of those conditions, if we are able to find them early on and start treating them, can greatly change the prognosis for that child. So in many ways, the diagnostic testing can greatly change our management and treatment of someone. And that can lead to very good results. As I mentioned before, diagnostic testing could lead to cascade testing. And then of course, cascade testing could be leading to finding other people who either carry or have a genetic condition. Sometimes, in some cases with genetic diseases, a diagnostic test is actually required to get certain types of treatment or funding for certain types of treatment. So for some people, they actually need the diagnostic test to be able to have their disease funded properly and to be able to get access to the treatment that otherwise they wouldn't be able to get access to. And in some cases, people with certain diseases, diagnostic testing can just be a way of finding out what is actually causing their disease. So it may just end that individual search for the cause of their disease. So there's various reasons, and again, this isn't covering all of them, but there are various reasons why we want to do diagnostic testing. This is my last slide here. I wanted to bring up direct-to-consumer testing. I'm not actually going to really talk about it at all, but I brought it up just because I'm sure it's something that many of you have thought about. The reason why I didn't talk about direct-to-consumer testing like 23andMe, Ancestry.com is really because these are more novelty types of genetic testing. They're usually not medically relevant. The results of them are not usually medically relevant. And if you were to do something like 23andMe and then bring those results to your doctor, usually they're not something that we can really use to guide any sort of treatment or management. So this is just something that I wasn't going to talk about, but I just thought I would bring it up simply because it is quite popular. And I will do a small plug though for Dr. Gare. She is actually going to be doing a talk sometime next year. I think, is it in March, Dr. Gare? You said you're doing a talk on this. I don't know if you want to briefly.
Yes, March 1st and 3rd.
Okay.
Yep, through continuing studies. But yeah, so watch for that.
Yeah, so if you are interested in this topic, then definitely check in for Dr. Gare's talk next year in March. And that is the end. I have some resources that I've put in here. Of course, your healthcare provider is a great resource for talking through genetic testing and options if you're curious about genetic testing. I did mention gene therapy was something that's quite new and interesting, but there's not really any time to talk about that in this talk. So I've put in a couple of links here. This is a link specifically for gene therapy being researched for cystic fibrosis. I've also put in a link here for something called CRISPR. This is one of the tools that's being used in gene therapy. I've also put in some other links for other websites that can give you a lot of good information on this topic. So HealthLink BC has some nice information on genetic testing. Perinatal Services BC has a lot of great information on perinatal screening and, prenatal screening and newborn screening. Medline Plus is a website that comes from the US. It's a government website that gives a lot of great information on genetics. OMIM is another website. It is basically something where you can search up different genes and genetic diseases. National Human Genome Research Institute, this is also coming from the US. Again, a lot of great information on genetics. And then I've just put in some other websites you can go to. Medscape is a good website if you're looking for something that goes into things in a lot more depth and a lot more detail and uses a lot more technical language. A couple of other sites that's good for this and just for other general things related to medicine are Mayo Clinic and Cleveland Clinic. Thing I usually go for is if it's .gov or .org, I usually trust it a little bit more than something that's just a random .com. So that'll be provided when the slides are posted, so you can definitely check this out and go to some of those links. And then I just want to mention our future talks that are coming up. So next Sunday, Nicole is going to be doing a talk on diabetes. And then next year we have several more talks going on. So we have 3 in January and another 3 in February. So thank you everyone for coming out here. And I see there's lots of posts in the chat. I don't know if these are questions, so I'll check those out. But again, thank you for joining us. If you are wanting to move on to something else today, you can definitely leave this. Otherwise, I'll stick around here and try to answer some questions as best as I can.
Thank you so much, Drew. And yeah, thank you everyone for coming. It's so nice to see so many familiar faces and names and see you all here again. That was really great. And the questions in there, I hope I addressed them, Drew. So I don't think there's anything outstanding. It was about whether BRCA1 and 2 mutations can be passed on to sons. And so, yep, they can. And that males are also susceptible to breast cancer and the other cancers caused by BRCA1 and 2. Yeah, but yeah, if there are any other questions, let us know.